Okay, picture this. You're over 65, you're sitting on that crinkly paper in the doctor's office, and you're watching the nurse write down your blood pressure. You probably know exactly what's coming next, right? You are about to be told for the 100th time that your number needs to be pushed down. Well, welcome to this explainer. Today, we're taking a deep dive into the actual science of senior cardiovascular health, and we are going to completely dismantle a medical myth that millions of people are living with every single day.
We've all heard the exact phrase, that number needs to come down, below 130/80. Or maybe it's the classic, your pressure is a little high today, we should really talk about upping your medication. And look, if you're like most people, you trust this. It's standard medical advice. You go home and you either start taking a brand new pill, or you force yourself to cut out even more salt, you try to walk more, and honestly, you just worry more. The message you received was crystal clear, lower is always, always better. Just get that number down, full stop.
But here is the absolute bombshell that most seniors are never going to hear in that exact same 15-minute appointment. The idea that lower is always better, it isn't just an incomplete picture. For a huge percentage of adults over 65, it is actively wrong. The research supporting a way more nuanced view of blood pressure in older adults has actually been building for years in major cardiology journals, all while millions of seniors just continue to be managed under these generic, one-size-fits-all targets that, frankly, were never designed for their specific physiology in the first place.
So let's break this down. Section 1, the science of the aging artery. Understanding your numbers.
Let's start with the basics, because confusion right here is literally costing seniors their health. You have two distinct components to your blood pressure reading. On the left, we've got the top number, the systolic pressure. Think of this as the squeeze. It measures the sheer force your heart generates when it contracts and pushes blood out into your body. Then on the right, you have the bottom number, the diastolic pressure. This is the pressure in your arteries between heartbeats, when your heart is just resting and refilling with blood. Now, for decades, old-school medicine hyper-focused on that bottom number. But by the 1990s and 2000s, the top number became recognized as the much more important predictor of cardiovascular risk for anyone over 50.
Here is why that matters. As we age, the walls of our large arteries stiffen up and they lose their natural stretch. Think of it less like a flexible rubber garden hose and more like an old rigid metal pipe. Because they're stiff, they can't absorb the forceful shock of a heartbeat as easily. This naturally drives that top number higher, even while the bottom number stays totally normal. Now listen closely here. This arterial stiffening is a totally natural biological process. It's kind of just what aging bodies do. It is absolutely not identical to the chronic cardiovascular damage you'd see in an unhealthy 45-year-old. And critically, treating a 75-year-old stiff arteries aggressively with the exact same targets used for a young adult, that introduces a whole new set of severe risks.
Which brings us to Section 2, Hidden Dangers in Guidelines, the SPRINT Trial.
To really understand why 130/80 is everywhere, we have to look at the SPRINT Trial. This was a massive, landmark, federally funded study that pushed all the clinical guidelines down. They took over 9,000 adults and compared a standard systolic target of 140 against an intensive, aggressive target of below 120. Now, looking at the left column, the headline benefits were, admittedly, dramatic. The intensive group had significantly fewer heart attacks, heart failures, and strokes. It was so compelling that guidelines were updated almost overnight. But look over at the right column, the hidden harms. In that exact same intensively treated group, acute kidney injury was 50% more common. There were dangerous electrolyte imbalances, way higher rates of falls requiring a hospital visit, and more cases of syncope, which is a medical term for suddenly passing out. In older, frailer adults, this trade-off between a possible heart benefit and a guaranteed serious harm shifts really dangerously. And yet all of that nuance was lost, and the massively oversimplified get below 130/80 became the default marching order for millions.
All right, moving on to Section 3, the J-curve in falls. This is where lower actually becomes dangerous.
So I bet your doctor has never mentioned the J-curve phenomenon to you, but they should. When researchers zoom out and plot blood pressure against actual cardiovascular outcomes across massive populations, the relationship does not look like a simple straight slide where lower is always better. Actually, it looks exactly like the letter J. As your blood pressure drops below a certain specific threshold, the risk of heart events and organ damage doesn't go down, it actually starts to hook back up and rise again. There is a hard floor where pushing blood pressure lower stops preventing harm and starts actively causing it.
And for older adults, we know exactly what that dangerous floor is. It's a diastolic or bottom number of 60. Study after large study has found that a diastolic pressure dropping below 60 to 65 is directly associated with an increased risk of heart events, cognitive decline, and organ damage. And here's the why behind that. Remember, between heartbeats, when your heart rests, that is when your coronary arteries do almost all of their filling. If that bottom resting pressure drops too low, there's just not enough force to push blood into the heart muscle. So a bottom number of 58 isn't just a harmless number on a screen. It might represent genuine ischemia. Basically, your heart tissue is being silently starved of oxygen with every single beat.
And this oxygen starvation leads us right into orthostatic hypotension, an issue that profoundly threatens the physical safety of seniors but is incredibly swept under the rug in routine medical care. This is a massive, sudden drop in blood pressure that happens the second you stand up from a chair or get out of bed. We've all felt it, right? It's that momentary dizzy spell, that scary split second where the world just sort of tilts sideways before your circulation can catch up. Now, in a 35-year-old, it lasts 2 seconds and you forget it happened. But in a 72-year-old, especially when 4 different blood pressure pills are making that drop way larger and way longer, that dizziness is literally a bone fracture just waiting to happen.
To really put that into perspective, I want to show you one very grim number: 30%. That is the 1-year mortality rate for a hip fracture in an adult over 70. Almost a third. A medication-driven fall is absolutely not a minor side effect of your blood pressure pill. It is very often the first domino in a terrible cascade that ends a person's physical independence forever. And yet, maddeningly, when doctors are relentlessly setting these blood pressure targets, what the patient's pressure actually does when they stand up on their own 2 feet is almost never systematically checked.
Okay, let's ground all this heavy medical stuff in reality for a second. Let me tell you about Margaret. She's a 78-year-old woman who had been totally stable, feeling great for years, with a top pressure hovering right around 142. But her well-meaning cardiologist, chasing that new guideline we talked about, doubled her meds to shove her below 130. Well, her top number came down, sure, but as a result, her bottom number plummeted to a dangerous 58. Her standing pressure dropped so severely that she suffered 2 bad falls in just 6 weeks. Margaret's physical safety was entirely destroyed simply because her doctor was treating a chart instead of a patient. Luckily, they caught it. Her doctor stepped the medications way back, and guess what? Her dizziness vanished, she went right back to her daily walks, her long-term cardiovascular risk barely changed at all, but her immediate day-to-day safety was completely restored.
So, what do we do with all this? Let's get into Section 4, taking control of your target. Precision versus permissiveness.
The good news is geriatric specialists, the doctors who actually study aging, support varied ranges based on your actual specific body. If you're between 65 and 75 and you're active and functioning well, a top number between 130 and 140 is generally fully supported by the best research. But if you are over 75, and especially if you are frail, managing multiple medical conditions, or have a high risk of falling, a target of 140 to 150 is increasingly recognized as the right, individualized goal for you. Letting the numbers sit a bit higher isn't doctors just throwing their hands up and being permissive, it is actual targeted precision medicine.
Okay, so let's wrap this up with a highly actionable 5-step toolkit you can literally take to your very next doctor's visit. Step 1, check your diastolic average. If that bottom number is sitting below 65, flag it immediately. Step 2, track your numbers at home, twice a day for 2 solid weeks using a good quality upper arm monitor. Step 3, don't be afraid to politely ask your doctor for the specific logic behind your target. Ask them, does this number account for my age, my fall risk, and my kidney function? Step 4, if you ever feel dizzy standing up, use the exact medical phrase orthostatic hypotension and demand a standing blood pressure test in the office. And finally, Step 5, if you're over 75, they've pushed you below 130, and you're feeling a bunch of unexplained brain fog or fatigue, strongly question if the intensity of your medication is actually the culprit.
I want to leave you with one final provocative thought to chew on today. Are you managing a number, or are you managing your life? Because managing blood pressure after 65 is absolutely not about blindly following a simplified, one-size-fits-all chart printed out in a clinic. It is about understanding what your individual, changing physiology actually needs to thrive. The research out there clearly supports nuance, and your health, quite frankly, deserves that nuance. So take these tools, ask the right questions, and ensure your medical treatment is actually serving your independence, not threatening it. Thank you so much for tuning into this explainer, and we will definitely see you next time.